Hello, everybody. My name is Joe Willis. I'm a gastrointestinal pathologist at Case Western Reserve University. I'm here to present the work of our team, which has investigated and identified aneuploidy on a esophageal brush as a potential new approach for detecting cancer and precancerous lesions of the esophagus. I do have some financial associations with a company called Lucid Diagnostics. However, none of these relationships will be in vogue in this particular presentation. So esophageal adenocarcinoma is a large unmet problem currently in the United States. Esophageal adenocarcinoma is the fastest growing solid tumor in the United States, with an unfortunate 5-year survival rate of less than 20%. This occurs for two reasons. One, it's seldom detected early enough for localized therapy, and also inherently the tumor is a relatively aggressive cancer in its own right. So for those two reasons, the 5-year survival rate is relatively poor. This increasing incidence of esophageal adenocarcinoma in the U.S. is also has occurred in parallel with increasing incidence, at least in the so-called Western world. The graph I'm showing on the right from Hoffman et al. From the British Journal of Cancer 2018 also demonstrates these increasing incidence of esophageal adenocarcinoma. The upper black curve represents increasing incidence in males, and the bottom occurs in females. And even though this cancer has a less of recurrence in females opposed to males, you can see clearly that in actual fact it's increasing in both gender groups. Also, I want to mention that the esophageal adenocarcinoma is a cancer that has about the same mortality incidence as mortality rate as ovarian cancer, to show that is in actual fact a significant problem. Now, what causes esophageal adenocarcinoma? The only known precursor lesion to esophageal adenocarcinoma is this concept of Barrett's esophagus. What is Barrett's esophagus? Is an entity that occurs in the lower/distal esophagus of patients with gastroesophageal reflux. What this is a metaplastic change. So as you can see from the panel on the lower end of the screen, the normal esophagus is lined by squamous epithelium, very similar to skin. And then with inflammation in the second panel, that you can make out all this sort of disruption of the surface, and also this, even at this low power, you can see under the epithelium these chronic inflammatory cells. They're caused by inflammation secondary to reflux from the stomach into the esophagus. In the third panel, there is a histologic picture of what changes in the esophagus, changing the squamous epithelium to this glandular sort of colon-like epithelium. And the reason why this occurs is that the esophagus has realized that if you change the lining of the esophagus in the presence of reflux from squamous to glandular, you prevent the formation of an ulcer. So this is a protective effect. But unfortunately, everything has a cost. And in the presence of metaplasia of the esophagus, there's an increased incidence of dysplasia, the precursor lesion to cancer, in the fourth panel, and then ongoing into invasive adenocarcinoma. So there's a direct correlation between reflux, Barrett's esophagus, and esophageal adenocarcinoma. So Barrett's esophagus is a fairly common entity. It affects about 1 to 2% of the general population in the U.S. However, the annual progression rate to esophageal adenocarcinoma is relatively low. It's 0.1 to 0.5% per year. And this equates to about a 1.2 per 1,000 person year progression rate. So right now, so that is relatively low, given the fact that 1 to 2% though of the population have in actual fact Barrett's esophagus. it's the fact that there's such a high incidence of Barrett's esophagus, even though the rate of progression is low, that gives us this current problem that we have. Dysplasia on Barrett's esophagus is based on a biopsy that somebody like me would review from a gastroenterologist derived specimen, is by far the best biomarker we currently have for esophageal adenocarcinoma, by far. However, in spite of that, it's not very good. For example, about 15 to 40% of all patients with Barrett's esophagus are diagnosed with dysplasia at some point in their follow-up, in spite of the fact that there's only a progression rate of 0.1 to 0.5% per year. The reason for that is that there's a discrepancy in this dysplasia versus outcome paradigm, because reflux has its own effect on Barrett's esophagus and makes Barrett's esophagus biopsy samples often overlap with what the morphologic features of dysplasia itself. So that's a well-recognized problem. Nonetheless, to detect Barrett's esophagus, and if we detect Barrett's esophagus and we detect patients with dysplasia, we can actually prevent those patients from developing esophageal adenocarcinoma. Very similar to removing a polyp in somebody's colon, thereby preventing the formation of a cancer at that site of the polypectomy. The exact same concept. So this is a big deal. So then endoscopic surveillance then is the current way that patients with known Barrett's esophagus are put into a care path program to prevent the formation of a cancer. So the patients undergo a periodic endoscopy with biopsies for dysplasia. And as I mentioned already, even though this is by far our best current system, there are difficulties in this system associated with interpretation of some of the Barrett's esophagus esophageal cellular changes. We call it a lot of these dysplasia, and they're probably not. Also, the fact is that there's random sampling in a segment of Barrett's esophagus, and by definition, the random sampling is not going to pick all the areas of invasive or dysplasia or cancer, and may miss them. Also, then, advanced cancers still occur during screening surveillance, interesting enough. And so probably that represents patients who had surveillance, but then had in the surveillance underwent random sampling, but the sampling missed the area of dysplasia or early cancer. Also then, as I mentioned from the previous slide, most patients who undergo surveillance actually should not even undergo surveillance because they do not develop dysplasia or cancer. But we right now have absolutely no way of defining which patients with Barrett's esophagus will and will not develop dysplasia and cancer. So at best you can say that endoscopic surveillance is a high-cost, moderate-yield procedure. So just to take on a different tack, we use aneuploidy in this study that I'm going to present to you to help identify patients who have a high risk of developing cancer. As I'm sure most of the audience knows, aneuploidy is defined as a chromosomal aberrations which occur during cellular division. And these represent some of the first recognized features of human cancer cells. In actual fact, if you look at this concept of some abnormality in cancer nuclei was actually identified as an association with cancer even before the concept of DNA was figured out. So in the field of Barrett's esophagus research, it has long been recognized that aneuploidy has a potential basis not only to understand the concepts of how Barrett's esophagus progresses to cancer, but also to leverage that knowledge as a potential biomarker of progression risk. In spite of that, however, even though there's been 30 years of excellent research in this field, in Barrett's esophagus in particular, this concept is not used clinically very widely. The reason is there's still a lack of complete understanding of the role of aneuploidy in the process of Barrett's esophagus progressing to dysplasia and cancer. current clinical trials use, similar to the concept I said about surveillance and taking random biopsies. This is also true for patients with Barrett's esophagus who have undergone clinical trials associated with looking at aneuploidy as a marker for progression. The same problem applies of sampling. Also, there are significant technical hurdles to bringing these technologies into a clinical space, which I won't elaborate on. So what we have done then, we've leveraged a new technology that came out of the Bert Fogelstein lab in Johns Hopkins. And many people probably have heard this technology called RealSeq-S. This is a really excellent technology, in many ways groundbreaking technology, whereby the Hopkins group identified this new technology as a blood test to identify patients who have circulating tumor cells in their blood. And what they did was, using a single primer pair, amplified over 350,000 repetitive elements that were present across the genome, and then going through this sort of schema, high power view schema of excluding failed samples, comparing results to normalized patients known not to have cancer, and then visualizing what is here in the upper right panel, chromosomal aberrations, either deletions or amplifications across the chromosome. We're able then to come up with the identification of circulating cells that had marked aneuploid compared to the normal samples in the bottom right panel here. So this has really been this is a very successful, well-publicized technology that we felt would be potentially useful for Barrett's esophagus. So as I said, we had this concept. We thought that if we could use this concept of, instead of using blood samples, but actually using esophageal brushings, extracting DNA fragments from brushings, we could use this technology to identify dysplasia. So this process would give us a simplified workflow. It would require small amounts of DNA. It actually achieves a higher sensitivity with less sequencing than whole genome sequencing by using current technologies. And also, it has a well-defined pipeline, so the computational component has been, as it were, locked down. And what we did was, we used this technology in the study I'm going to elaborate on to develop a global aneuploid score, which we call GAS. And then we also, on top of that, looked at specific driver chromosome abnormalities associated with esophageal carcinogenesis. So this is the summary of the data I'm going to support. This schematic diagram here on the left, we start with esophageal brushings. We isolated DNA from these brushings in a large patient cohort, sequenced them using the single primer pair concept I mentioned to you just a minute ago, using the RealSeq-S platform, identified chromosomal aberrations. So we did this, what we did was, using the RealSeq-S analysis, identified aneuploidy in these specimens, and then went a step further and used assessment of individual chromosomal abnormalities associated with esophageal carcinogenesis to develop this process. And we identified a set of results that really validate our concept. We identified in about 7.3% of patients non-dysplastic Barrett's that were aneuploidy, plus had this high abnormalities in chromosomal driver genes. The chromosomal driver gene decision process was called BAD. This stands for Barrett's analytic decision. High-grade dysplasia we found, and associated with a bad result, was found in about 70%, and about 96% of our esophageal cancer patients had this abnormality as well. So this is what we found. Firstly, looking at aneuploidy on these samples. You can see that this graph shows exactly what you would expect, that normal specimens on the left corner showed no aneuploidy effectively, whereas on the right side, esophageal adenocarcinomas showed aneuploidy, a high concentration of patients with aneuploidy. The y-axis, called the GAS score, is our aneuploidy score, and anything above 0.6 is regarded as having aneuploidy. And then the second part of this was identifying that high-grade dysplasia actually was also associated with a significant amount of specimens with aneuploidy. And then we also found that the majority of low-grade dysplasia patients were also identified as having aneuploidy. Just as an aside here, these low-grade dysplasia patients are highly annotated. They come from a known patient population, and I reviewed all these samples, so we're pretty confident that the majority of these low-grade dysplasia patients did in actual fact meet the sort of a pathology criteria for the presence of dysplasia. And now, so this actually was also very interesting in that we found that the vast majority of our non-dysplastic Barrett's here in the red part of the graph, at the bottom you see this bulge at the bottom, showed the absence of aneuploidy, whereas at the top you can see that there was nonetheless a certain number of patients whose non-dysplastic Barrett's were in actual fact aneuploidy, and we'll mention that in a minute. So not only did we have this, we had this aneuploidy aspect, but as I mentioned already, we were specifically interested to see whether not only global aneuploidy, but whether abnormalities in known driver chromosomal changes were associated with an increased likelihood for a patient to have cancer or progress to cancer. So these were the chromosomal changes we were specifically interested. 1q gain, which is a common chromosomal change found in multiple cancers. 9p loss, which is the p16 locus, which is a well-recognized driver gene associated with esophageal adenocarcinoma. 12p gain, as everyone knows, this is the KRAS. KRAS is a known driver of esophageal cancer. And 17p loss, the p53 locus, and the 20q gain, which is a segment of a chromosome that has a number of different genes that have been associated with multiple cancers. Also, we've been very interested in focal changes in the c-MYC gene as well. So our idea was that we look at cases that had a aneuploidy score of greater than 0.6, and then if not, then we, by definition, we would say our Barrett's aneuploidy decision classifier was negative. So therefore, then we thought this was a low-risk specimen. If there was a gain or loss of one of these pre-selected chromosomal changes present in the box in this slide, then we would say yes. In actual fact, we think that this is a potential driver gene abnormality, and we think this is a high risk of being a neoplasm associated with cancer. And if this was not present, it would be classified as an indeterminate aneuploidy without a chromosomal aberration. And then if there was aneuploidy with an aberration, then we would call it very bad. And as you can see, since we're all in the GI field, we really worked very hard to have something that was called a very bad gas as something that was bad. So this is another way of looking at our data, in that we found that the vast majority of non-dysplastic Barrett's were not associated with aneuploidy. And then at this cutoff, then, as you progress from non-dysplastic Barrett's, where there was an increased number of specimens that had aneuploidy and some with focal gains in the chromosomes that we had mentioned, all the way as you progress further into sort of an advanced non-dysplastic Barrett's and in the neoplasms associated with esophageal carcinogenesis. So this is our concept of how this progresses. So one way to look at our data is to look at, well, I'm going to present the raw data on the training sets and validation sets. And you can see that this data set shows a training set with the red bar shows the final classifications of specimens in different categories. And the categories are very bad. This is associated with chromosomal changes plus aneuploidy. The second category is aneuploidy alone. And you can see that the addition of the chromosomal abnormalities does in actual fact increase the specificity of the assay in decreasing the number of so-called, what we think would be false positives, especially highlighted here in the non-dysplastic group. So then with that, you can see that esophageal adenocarcinomas were classified as very bad in 90% of cases. 60% of our high-grade dysplasias were called very bad, and non-dysplastic Barrett's esophagus patients, interestingly, 5% of those were in actual fact called very bad. And in the validation set, using the same sort of concept of the aneuploidy and then the very bad classification, which used the chromosomal changes associated with aneuploidy, we had very similar results. About 96% of our esophageal cancers on brushing were esophageal adenocarcinomas on brushing were found to be very bad. About 70% of high-grade dysplasias were found to be very bad. Half of our low grades were found to be very bad, and 7% of our non-dysplastic Barrett's were in actual fact found to be very bad. So just to give you this in a sort of a more concise format, if you include both the training sets and validation sets, you can see that from this table, the variable on the left side includes our controls and non-dysplastic Barrett's all the way to cancer, and then the different columns represent whether something was called very bad or maybe bad, which is aneuploidy without a specific high-risk driver gene chromosomal change. And you can see that, for the most part, there's a very significant progression for non-dysplastic Barrett's all the way to cancer in a sort of a way that you would expect, with the vast majority of non-dysplastic Barrett's having this very interesting process of aneuploidy with and without chromosomal change. So just to mention one thing about how good is this assay in terms of concordance, we actually had a number of samples, 22 samples that we had, 22 patients for which we had more than one sample. And you can see that very interestingly, there was a high concordance rate in the first column between the concordance rate of positives. In 11 cases, we did very well. In concordant negatives, we also did very well. We only had one discordant case. That was in one patient with a low-grade dysplasia, where one sample was found to be positive and a follow-up sample was found to be negative, which is remarkable, really, at this stage. So one thing to talk about is, well, how did you miss some of these high-grade dysplasias? Well, we think some of that is in actual fact a sampling issue. And what this is that in most of our cases where we missed our high-grade dysplasia, they were found to be very small. And most of the misses were either very small, or the misses were found mostly in very short or very long segment Barrett's esophagus. So and this is probably related to the fact that the brush became either, if it was a long segment Barrett's, overpopulated with a large amount of material, or very short that was simply something related to not being able to pick up the brushing per se. We think both of pick up the neoplasm per se. We think both of these issues can be fixed by having more than one brush in patients, especially with long segment Barrett's esophagus, for reasons I think are fairly obvious. So then what about our ability to predict progression? So then we did have the ability to follow up some patients with non-dysplastic Barrett's esophagus who were classified as very bad. So in reality, we had 4 patients, 2 of the 4 patients that we classified as very bad non-dysplastic Barrett's esophagus, in actual fact progressed, which is really remarkable given the overall low risk of progression at any length of time in these patients. The fact that we identified 2 of 4 who did progress in over 36 months shows that there's really we feel that this is a really good indicator that we're onto something pretty important here in terms of technology. Also importantly, none of the 56 that we called not bad or maybe bad, remember maybe bad is aneuploidy alone without a significant chromosomal driver gene abnormality, and none of those 56 progressed in that period of time. So a really significant p-value in that concept. And we are obviously still making sure that those 2 patients with a very bad non-dysplastic Barrett's are going to be followed to see what actually happens to them, to make sure they're not lost to follow-up, etc. So therefore then we have this concept. We think that we may have an ability to replace or supplement random biopsies with brushings for patients undergoing Barrett's esophagus surveillance for cancer. So our conclusions then are combining esophageal brushings and selective aneuploidy assessments can identify so-called not bad versus very bad Barrett's esophagus, and may allow for more sensitive molecular surveillance for early detection of progression to cancer, while preventing overdiagnosis and overtreating patients with low risk of Barrett's esophagus being detected by screening. If this is the case, then if we are then able to validate this concept going forward, we think that this could find a place in the armamentarium of patients undergoing surveillance for Barrett's esophagus in the near future. However, there's one thing that we really need to do this, and is obviously to validate our concept. So right now we have partnered with a national clinical trial to test the presence of, test for the accuracy of the very bad diagnosis in prediction and detection of progression in patients with non-dysplastic Barrett's and low-grade dysplasia populations. So this process is coming to fruition very soon, and hopefully these trials will start certainly by the end of this year, hopefully. So then in summary, I'm here obviously as a member of a group, and there are many people who have been involved in making this study successful, including, and I don't think any introduction is needed, to the Vogelstein group and Johns Hopkins. In particular, a shout out to Chris Duvall, who did a lot of the bioinformatics approach on this particular study, and was also the first author on the original RealSeq-S project. The Barrett's, we have a crackerjack group of collaborators in acquiring specimens for us throughout the U.S., and you can see these names here are all some of the thought leaders in gastroenterology overall. And here at Case Western Reserve University, I here represent Sandy Marcos, Amsab Chop, and Helen Moinova, that we've been working together for many years on Barrett's esophagus project. And clearly this sort of work takes a lot of funding, so you can see our funding sources here, and for which we are very grateful. So with that, I would thank you very much for your attention.